Welcome in. Let's make it breezy. Learning meds with Pharmacy Made Easy. Constipation. It is one of the most common yet often overlooked digestive issue affecting millions worldwide. But what really causes it? Is it just about the fiber, or is there more happening deep within the gut? So in this video, we will explore the science behind the constipation, the different types, and how medical professional approaches its diagnosis and treatment. Whether you are a student or a healthcare provider or someone looking to better understanding about your body, this is the place to start. Stay tuned as we break down the causes, symptoms, and the modern treatment strategies for managing the constipation, backed by the latest clinical insights. Let's dive in. Before we dive into the main topic of constipation, let's see the journey of the food from the mouth to anus. So, have you ever thought about what happens after you take a bite of your favorite food? Behind every chew, swallow, and digest lies a fascinating journey, one of that fuels your body, sustains your life, and operates with incredible precision. So, welcome to the journey of the food from mouth to anus. So, first one, digestion begins in the mouth. As the teeth break food particle into smaller particles, saliva, which is rich in the enzymes like amylase, start breaking down the carbohydrates. The tongue helps mix the food into moist ball called bolus that is ready to be swallowed down. So next, coming to the pharynx and esophagus. Next, the bolus pass through the pharynx and into the esophagus, a muscular tube that transports the food to the stomach. This movement is powered by the peristalsis. Peristalsis is nothing but the wave-like contractions of the muscle that pushes the food downwards. So from there, it reaches to the stomach. In the stomach, digestion intensifies. The bolus is churned with the hydrochloric acid and digestive enzymes like pepsin, breaking the proteins into the smaller fragments. The food turns into semi-liquid substance called chyme, which is slowly released into the small intestine. So after the food reaches the small intestine, this is an powerhouse of the digestion and absorption. In the duodenum, chyme mixes with the bile from the liver and the enzymes from the pancreas, helping breaking down the fats, proteins, and carbohydrates. Nutrients are absorbed through the intestinal walls into the bloodstream, primarily in the jejunum and ileum. From the small intestine, now it enters into the large intestine. What remains now enters into the large intestine or colon. Here, water and electrolytes are reabsorbed and the beneficial gut bacteria ferments any undigested fibers. What is the result? The formation of the stool. So, from the large intestine, it passes to the rectum and the anus. Finally, the stool is stored in the rectum until it's ready to be expelled through the anus. This final stage defecation is controlled by the voluntary and involuntary muscles that ensures the elimination is a timely and coordinated. So from a simple bite to the complex biochemistry, the digestive system is a marvel of human physiology. Understanding this journey not only helps us appreciate our bodies, but also empowers us to make the healthier choices. So now let's deep dive into our main topic, that is constipation. Constipation is defined as infrequent bowel movements, that is less than 3 times per a week, or difficulty in the passing stools. That means if straining, is it lumpy or the hard stool, pushing for more than 10 minutes, stool is requiring the digital evacuation, or the sensation of incomplete evacuation. The constipation can be caused by the diet, lifestyle, drugs, and pregnancy, GI disorders, and other medical conditions. Where constipation persists for several weeks or longer and the cause is unknown, this is termed as an chronic idiopathic constipation, CIC. Idiopathic constipation associated with the chronic or the recurrent abdominal discomfort that is relieved by the defecation is termed as irritable bowel syndrome with constipation. Now let's see what medical conditions can cause the constipation. One is irritable bowel syndrome, that is a constipation predominated, while anal disorders like fissures, fistula, or rectal prolapse, in multiple sclerosis, if there is any cerebrovascular events, or Parkinson's disease, spinal cord tumors, diabetes, and hypothyroidism. Now let's see what drugs causes the constipation. The first one is aluminum or calcium based antacids, and the medicine used to treat diarrhea, antidiarrheals, and the clonidine, a blood pressure medication, and cholestyramine used for cholesterol control, and the medication with an anticholinergic effect such as allergic drugs like diphenhydramine, muscle relaxants like baclofen, antipsychotic agents like prochlorperazine, and the tricyclic antidepressants like amitriptyline, nortriptyline. And the bladder controlling medications such as oxybutynin is likely to cause the constipation. And the other drug is iron supplements may also cause the constipation. Non-dihydropyridine calcium channel blockers, especially verapamil, and the narcotic painkillers or opioids may cause us the constipation. Now, to understand the constipation and its treatment, it's essential to begin with the basics of gastrointestinal water and electrolyte balance. The consistency of the stool is primarily determined by its water content, which typically constitute around 70 to 85% of the total stool weight. Each day, the gastrointestinal tract handles approximately 8 to 9 liters of the fluid derived from both ingested and secreted sources. However, after the process of digestion and absorption, only about 100 ml of this fluid remains in the form of an fecal water. The absorption of this fluid occurs mainly in the small intestine and colon, driven by the osmotic gradients. These gradients facilitate the uptake of water and electrolytes. Any disruption in this finely tuned system, whether due to a neurohormonal mechanism or a disease stage or drug effects, can impair the motility. These imbalances may lead to either constipation or diarrhea. Now let's see the pathophysiology of the constipation. Constipation develops when this balance is disturbed, most often due to the reduced fiber intake, neurological or hormonal condition, or adverse effect to the drugs. However, it is not always that simple. In fact, up to 60% of the individual with a chronic constipation have normal transit through the colon, complicating the diagnosis. So now clinically, constipation can be divided into two major dysfunctions. One is slow transit constipation, where the movement through the colon is sluggish, and the second one is outlet obstruction, where defecation is impaired due to the pelvic floor dysfunction or rectal issues. So let's see what is the colon role in motility. To understand how constipation develops, we must appreciate the colon function. It not only absorbs the water but also mixes contents via muscle contraction. If these contractions slow down, known as a decreased mass action, the stool remains in the colon too long, becoming the dry and hard. Conversely, overly frequent but ineffective contractions termed as non-propulsive movements, this can lead to the blockage and incomplete evacuation. Ultimately, whether the motility is too slow or inefficiently fast, the result is the same: impaired stool passage and clinical constipation. Now let's see the treatment. Non-drug treatments are preferred for the constipation. This includes increase the fluid intake, limiting the caffeine and alcohol intake to avoid dehydration, and increasing the physical activity. Replacing refined foods with the whole grain products, bran, fruits, vegetables, beans, and other foods high in the fiber is useful. It is important to avoid the delays in going to the bathroom when the urge to defecate is present. Younger children may need a scheduled time to use the bathroom. If possible, drugs that are constipating should be discontinued. Let's see the drug treatment. If constipation does not improve with the lifestyle measures, or if a constipating drugs cannot be stopped, one of more drug treatments can be used. Most medications are available over the counter and can be tried for the initial treatment. If the constipation is not improved after the several days of OTC treatment, a healthcare provider should be consulted for further evaluation, and if appropriate, prescription medicines can be considered. Most drug treatments act to stimulate the muscles of the digestive tract or soften the stool, often speeding up the time for the bowel movements. Thus, the most common side effects are diarrhea and abdominal cramping. In the drug treatment, the drugs range in strength and mechanism, from gentle stool softeners to powerful bowel cleaning drugs, are classified into laxatives, cathartics, and purgatives based on their intensity and purpose. Now let's explore what each of these terms really mean and how they work. First one is laxatives. Laxatives are the mild agents that promote natural bowel movement. They work by softening the stool or increasing its bulk or gently stimulating intestinal activity. These are often the first line of treatment for occasional or mild constipation. These examples include psyllium husk or isabgol husk, docusate sodium, and polyethylene glycol. In short, these agents that promote the evacuation of the bowels which are already formed and these are primarily used for relieving the occasional constipation. And the next one is cathartics. Cathartics accelerates the defecation, the intensity or moderate to strong. Coming to the mechanism of cathartics, they stimulate the stronger peristalsis or increase the fluid secretion in the intestine. The purpose of these cathartics are often used for the bowel cleaning, example before surgery or colonoscopy. And examples under this cathartic include the senna, bisacodyl or magnesium citrate. Note here is some consider cathartic a subset of the laxative with a more powerful action. Example, high doses of the castor oil or high doses of magnesium sulfate. The next one is purgatives. Those are the strongest drugs that causes the complete evacuation of the bowel. The intensity is very strong and the mechanism includes the powerful stimulation or an osmotic effect to completely empty the bowel. The purpose is used in severe cases, sometimes in the poisoning or before surgeries. So, in short, laxatives are the mild agents that promote the natural bowel movement which is already formed. And the cathartics are they causes the stronger stimulation of the intestine to speed up the stool passage. And the purgatives are they causes the complete evacuation of the bowels through the intense stimulation or a strong osmotic effects. Now let's see main class of laxatives. First one is a bulk forming drugs. Example, soluble fibers such as psyllium and the dietary fiber or the first line treatments in most cases and the treatment of choice in pregnancy. They absorb the water in the intestine which adds bulk to the stool. This increases the peristalsis and decreases the stool transit time. Coming to the second one is osmotics. Example, polyethylene glycol contain a large ions or a molecules that are poorly absorbed. They draw fluid into the bowel lumen through osmosis, which distends the colon and increase the peristalsis. Coming to the next category is stimulants. Example, senna or bisacodyl directly stimulates the neurons in the colon, causing the peristaltic activity. The patient using the chronic opioids, all of which are constipated, often require the stimulant laxative because opioids reduces the peristalsis and prolong the stool transit time. The stool softeners like Docicet can be given with the stimulant laxatives if the stool is hard. If the stool is not hard but the patient cannot push it out, stimulant along is usual treatment. So coming to the next one is the stool softeners. Example, the Docicets or the emollients that reduces the surface tension of the stool water oil water interface, allowing the more water and the fat to mix with the stool. This softens the fecal mass, making the defecation easier. These are frequently used by the patients using the iron supplements, which makes the stool harder and compact. Coming to the last one is lubricants. Example, mineral oil coat the bowels and stool with the waterproof film. This keeps the moisture in the stool and makes the defecation easier. I'm going to provide you the tips for the selection of an constipation drugs over the counter. So for most of the adults, start with the fibers. If this constipation is iron induced or a hard stool softeners like Docicet or a bulk forming drugs can be given. And if the constipation is due to the opioid usage, stimulant like senna, bisacodyl or osmotic agents like polyethylene glycol is given. And for the pregnancy, it is safer to start with give the fiber treatment. And if the constipation need to be fastly relieved, for the adults, the bisacodyl or glycerin, which are more gentle suppositories, and for the children, glycerin suppositories are recommended. If no improvement in the 7 days, refer the patient to the healthcare provider. Let's see each category of the drugs in detail. First one is a bulk forming agents. The examples include psyllium, calcium polycarbophil, methyl cellulose, wheat dextrin. And the contraindications for these bulk forming agents are fecal impaction and GI obstruction. Side effects with this bulk forming includes flatulence, abdominal cramping, bloating, bowel obstruction if strictures present, choking if powder forms are not taken with the NF fluids. Onset of action is within the 12 to 72 hours for these bulk forming drugs. So adequate fluids are required. Use with the caution if the fluid is restricted. Example, the heart failure and there is a difficulty in swallowing like in Parkinson's disease, or at a risk for fecal impaction Examples: intestinal ulcerations and stenosis. Separates a calcium polycarbophil from the select drug due to the binding interaction. These are sugar-free forms are available. Psyllium is modestly improve cholesterol and blood glucose levels. Now coming to the next class of the drugs for the constipation treatment are osmotics agents. Examples include magnesium hydroxide, milk of magnesia, polyethylene glycol, glycerin, lactulose, sodium and sodium phosphate. Coming to the contraindication, sorbitol is contraindicated in anuria, where lactose is contraindicated in low galactose diet, and Miralax, nothing but the polyethylene glycol, is contraindicated in GI obstruction. Side effects with these osmotic agents includes electrolyte imbalance, abdominal cramping, abdominal distension, flatulence, dehydration, rectal irritation with the suppositories. The onset of action will start within the 30 to 96 hours if taken orally and 5 to 30 minutes if given rectally. The magnesium containing products should be used with a caution in the renal impairment and do not use if severe renal impairment is present. The lactulose is commonly used for hepatic encephalopathy, and the glycerin suppository used commonly in the children who need to defecate quickly. Coming to the next category of the drugs is stimulants. Examples include senna and bisacodyl. Avoid use with stomach pain, nausea or a vomiting or a sudden change in the bowel movement that lasts greater than 2 weeks. Side effects with these stimulants includes abdominal cramping, electrolyte imbalance, rectal irritation, mainly with the suppositories. And their onset of action starts within 6 to 12 hours when taken orally and 15 to 60 minutes if taken rectally. Take oral products at the bedtime to induce a bowel movement the following morning. Can given 30 minutes after a meal to enhance the peristalsis. These are indicated mainly in the chronic opioid usage. Coming to the next category of the drugs in the constipation is then emollients or stool softeners. These are contraindicated where there is an abdominal pain, nausea, vomiting, use with the mineral oil, and OTC use greater than 1 week. Side effects with these emollients includes abdominal cramping, throat irritation, mainly with the liquids. The onset of action of these emollients or stool softeners will be 12 to 72 hours orally and 2 to 15 minutes if given rectally. So these are preferred when straining should be avoided. Example: postpartum, myocardial infarction, anal fissures and the hemorrhoids. Use when the stool is hard or dry. Do not take docusate and mineral oil together. It increases the absorption of the mineral oil. So coming to the next category, that is lubricants. Examples includes mineral oil. These are contraindicated for the age group below 6 years, pregnancy, bedridden patients and elderly. The side effects includes abdominal cramping, nausea, incontinence and rectal discharge. Onset of action for these lubricants are 6 to 8 hours when taken orally and 2 to 15 minutes if taken rectally. Oral formulations generally not recommended due to the safety concern. Example: the risk of aspiration and the lipid pneumonitis. Take the multivitamin at the different time due to the malabsorption of the fat soluble vitamins. Do not take these lubricants along with the docusate because it increases the absorption of mineral oil. In this video, so far we have seen the management of the constipation by following the lifestyle modifications or the drugs available in over the counter. Now, let's see other drugs that are used for the constipation. The prescription medications can be used if the constipation is not relieved with the OTC drugs or a lifestyle modifications. The few of the drugs includes the chloride channel activator, Lubiprostone, acts on the chloride channels in the gut, leading to increased fluid and peristalsis. Coming to the second one is guanylate cyclase C agonist. Example: linactolide increases the chloride and bicarbonate secretion into the lumen of the intestine, thereby increasing the speed of GI transit and reducing the abdominal pain. Coming to the other category, that is peripherally acting mu opioid receptor antagonist, that is PAMORAS. Example: albumiprone acts on the mu opioid receptors in the GIT, decreasing the constipation. Coming to the other category, that is a serotonin receptor agonist, Prucalopride releases the acetylcholine, which causes the muscle contractions and thereby increases the gastrointestinal motility. Now let's discuss about these drugs in detail. First one is chloride channel activator. Lubiprostone is indicated for chronic idiopathic constipation, irritable bowel syndrome with constipation where the constipation is predominated, and opioid-induced constipation. These are mainly contraindicated where the mechanical bowel obstruction, and the side effects with this lubiprostone is nausea, diarrhea, abdominal pain, headache, and abdominal distension. As methadone decreases the effects of lubiprostone, alternative treatment for the patient should be considered. Coming to the next prescription drug category, that is guanylate cyclase C agonist is linaclotide and can be indicated in chronic idiopathic constipation, irritable bowel syndrome where constipation is predominant. Linaclotide capsule should be taken after 30 minutes before the breakfast or on an empty stomach. The boxed warnings include do not use in the pediatric patient because they high risk of dehydration that can causes the death. Contraindication to this linaclotide is for the child aged less than 6 years and where there is an mechanical GI obstruction. Side effects with this linaclotide includes diarrhea, abdominal pains, and flatulence. Coming to the next category of the prescription drugs for the treatment of constipation is peripherally acting mu opioid receptor antagonist, that is albumopan. This is generally indicated for the hospitalized surgery patient to decrease the risk of post-operative ileus. Albumopan has potential risk of MI, myocardial infarction, with a long-term usage. Available only for the short-term inpatient used through a REMS program. The contraindications for this albumopan is therapeutic dose of an opioids for greater than 7 consequent days immediately prior to the use. The side effects includes dyspepsia. Coming to the final category of the drug, that is serotonin 5-HT4 receptor agonist, that is Prucalopride. This is indicated in chronic idiopathic constipation. The dosage for the chronic idiopathic constipation is 2 mg per day. And for the patient whose creatinine clearance is less than 30 ml per minute, 1 mg daily dose is recommended. And these Prucalopride should be added in patients with end-stage renal disease and hemodialysis. Coming to the contraindications for this Prucalopride is gastrointestinal obstruction, bowel perforation, ileus, severe inflammatory conditions of GI tracts like Crohn's disease, ulcerative colitis, and toxic megacolon. Prucalopride can cause this suicidal ideation, and the major side effects with this Prucalopride is diarrhea, headache, abdominal pain, and nausea. The worsening of the depression or emergencies of the suicidal thoughts, rectal bleeding, blood in the stool, severe abdominal pain should be monitored in the patient taking the Prucalopride. Now let's see laxatives used for whole bowel irrigation. Several laxatives are specifically designed to prepare the bowels before a colonoscopy. Some of these drugs contain the same active ingredients as those used for the constipation. For example, polyethylene glycol has the brand name Miralax that is used to treat the constipation. And the other examples like sodium phosphate, which is branded as an Osmoprep, and sodium sulfate, potassium sulfate, and magnesium sulfate. Last but not the least is the sodium picrosulfate. As the sodium phosphate or a Osmoprep is avoided in nephropathy. The contraindications of these drugs are ileus, gastrointestinal obstruction, gastric retention, bowel perforation, toxic colitis, and toxic megacolon. The patients on these drugs should be monitored for the arrhythmias, electrolyte abnormalities, or seizures. And the side effects with these agents include abdominal discomfort, bloating, nausea, or vomiting. The onset of this action is within 1 to 6 hours. Bowel preparation regimens typically require doses that evening before the colonoscopy and the morning of the colonoscopy to completely evacuate the bowel. A clear liquid diet is required the day prior to the colonoscopy and can include water, clear broth, beef or chicken, Juices without pulp, apple like white cranberry, white grape, lemonade, soda, coffee, or a tea without the milk or a cream. The clean gelatin without the fruit pieces, popsicles without the fruit pieces or a cream. Be given. Do not consume the following products like solid or semi-solid foods, anything with a red or blue or a purple food coloring, including the gelatin and the popsicles, milk, cream, tomato, orange or grapefruit juice, alcohol beverages, cream, and soups. So that's a wrap up on a constipation meds. And remember, always talk to your pharmacist, your healthcare provider before starting any new medication. Stay healthy, stay cheesy with Pharmacy Made Easy. Follow for more.